one nation, under God, indivisible, with liberty and justice for all. Now a reading of the mission statement. Is there someone who would like to read the mission statement?
I will.
Thank you, Dana.
Sure. Our mission, Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence.
Thank you, Dana. Item 3, is there a motion to approve the agenda?
So moved.
Motion by Selena, support by Lori.
Mark.
Or Mark.
Donna? It was Donna, it was me.
I'm sorry, by Donna or Mark? We'll say Donna. All right, all in favor? Aye. All opposed? Ayes have it. Item 5, hearing of the public. Is there anyone from the public wishing to speak to this body? Now is the moment to speak. Item 5A, request to approve residential lease A. And this has been approved by legal. Is there a motion?
So moved.
Support.
Motion by Selena, support by Lori, and discussion. TJ, do you have something on here? Do you have anything to add to it, or
Good evening.
Tracy? You're already up there, so might as well.
First, I'll mention that there is a mistake on here, and I know Nick would have picked it up, but I'll bring it up first. The insurance listed on page 5 should match the insurance listed on page 1, and I just noticed it. There's $1.50 difference there. So
Say $1.50?
yeah, I'll have that changed. The second thing that I would point out is that this is a 6-month lease. And Tracy and I are still working collaboratively on our leases. They're much more short-term. This lease is only 6 months because the provider has agreed to buy the home. But they're not quite ready to do that. They said they'd be ready to do it in 6 months, so we wrote a 6-month lease. That's why it's written for 6 months. The other thing that I'll point out, you'll see the highlighted item on page 3. We have parodied the HUD. It's called the HUD Useful Life Tool. And all of our leases now contain the language so that when we go to close out these homes that are 30 and 35 years old, we parody the HUD language that says if something is beyond certain years, we won't cost settle for it. So countertop, for example, if the countertop in HUD example says the countertop after 20 years is its end of its useful life, and we have a landlord that wants $1,000 for a new countertop, we now parody this language and it says, look, if it's over 20 years old, we're not going to cost settle for it. So we added that language. I just wanted to point that out, that you will see those in all future leases.
Yes, Nick.
I'm going to take it as a compliment that I would have cut.
That's right. It was a compliment. Nick.
But I didn't cut so a buck and a half because I didn't look that closely. I am a little concerned that we're bumping the rate up, the rent rate up for this short 6-month period. When, if we went to a month-to-month, we'd be at the current one. I understand we're already at a month-to-month. I assume that has something to do with negotiations with the owner.
We have about 65% of our leases now that are on a month-to-month lease. It puts us in a very precarious position to be on a month-to-month because the landlord has all the leverage. So we have stayed on a month-to-month because we are in a bit of limbo in messaging to our providers about taking leases on. Many of our providers simply do not have the money to take the leases on. So we then step in and offer a 2-year lease. In doing so, many of our landlords are saying, look, we got a haircut back in 2008. If you recall, Jim Losey and I negotiated downwards many of our leases. Many of those leases have not been renegotiated. And everybody wants a piece of the coin. So we're doing the best we can. 5% is the max kind of that we're going right now, which is still pretty low. Most of our homes are very underpriced as far as a lease goes.
Well, but we had learned years ago that purchasing them would be cheaper than like a couple of years of rent, which is what we tried to do, but had problems doing for a variety of reasons. The providers are now purchasing, apparently. We were also talking about the residents actually purchasing collectively and paying the rent directly rather than running through us, because that's what we're doing now. They use their social security to run through us. I know Pankatai was trying to work some of those things out. So those are all still in the works, so.
And the third tentacle is to,
Transition takes time, I understand that.
and the third tentacle was to ask the county to purchase leases as well. And Tracy could speak a little bit better to that. She has that
Well,
list.
I had led the charge several years back to try to allow us to purchase through the county building authority, and the county objected, so we couldn't do it.
Having our landlords, in a lot of cases, do not want to lease directly to the providers. It's an odd situation. They want the insurances that the county offers, and they do not want to lease to the providers. And it's even more difficult to lease directly to consumers.
The other problem is essentially what we do by serving as the intermediary. It's not with the providers, but with the residents, doing direct leases, is we level it off because they pay for they basically reimburse us for our residential costs from their social security disability, for instance, generally. And some have higher and some have lower, so it eliminates the position that somebody with low social security disability can't get in, and somebody with high disability kind of levels the playing field, but okay.
It's also really difficult, what I've heard from the providers, some of the rep payees that control that disability money are very reluctant to give that money up sometimes. So for the providers to be able to collect that money becomes difficult as well. Any other questions?
No other questions? All in favor signify by saying aye. Aye. All opposed? Motion carries. Thank you, TJ. Item 5B, request to approve the MEA campaign, Middle Eastern American, approved by legal. Is there a motion? Motion by Donna,
Support.
support by Lori. All right, Tracy?
You'll see in your packet, it describes it, but this is a request to approve the amount of $13,500 for about 100, don't hold me the exact number, forgive me if it's a few off, but about 120 advertisements, most of them being on the MEA TV with some radio spots on MEA radio. You'll also notice in there, basically, we're targeting this particular population. I'm sure you know that there's a stigma in any population, but this particular population, there is also a stigma associated with that. In Macomb County, it's estimated to be about 64,000 that I've identified to be either partially or solely associated with the Middle Eastern population. So it's just our additional efforts to reach out to this population. As soon as next month, I mentioned this to Ryan, we'll be bringing forth a more strategic campaign for marketing and advertising. This is just the most recent and immediate action that we're requesting for your consideration.
Any questions for Tracy? Phil?
Thank you, Ryan. Tracy, who's responsible for creating these ads? Is this something we're going to work with Airfoil on, and we're going to do it and then just hand it over to MEA to put out on their networks, or how's that going to work?
Both as an MEA partnership and with us, we give them the materials, right, our materials, and they also are asking to schedule an interview, essentially. Yeah, so we'll have the rights to approve, essentially, the message. The messages are going to be very, very simple, right? Like, we're here to help. Here's how you call. Here's what, how you get to us.
Thank you.
Mark?
Particular population.
Agreed, and that's why one of our efforts is to outreach through this mechanism. But we do have staff that are speak either Chaldean or Arabic, or I'm sorry, not Chaldean, Aramaic, or Arabic, and then we are partnering with them to get feedback from them about what's working and not working, essentially. Yeah, and then we do have ACA. They recently, I don't know, Helen, if you remember their formal name, the American Chaldean and.
Is that Martin Manna? Is that?
Yeah, they just changed their name, so I apologize why I'm struggling. But they are one of our providers. They're a great provider. We already have an established relationship with them, and they're wonderful at outreaching to that population. But they also do serve, that's where they're expanding, is all populations. But they definitely have a good expertise with that particular one. Yes, Access, that's is their former name. Thank you. They changed it to ACA, American. Nothing, no. No, I'm sorry. But you're right, it is the former Access. We already have a relationship with them. They do great work.
Any other questions? I just have one. Will we, as part of this targeting campaign, are we going to address all of the services we provide? So for every community, not just community, I'm sorry, all, DD, everything, including substance abuse?
We are, but again, the messages will be very, very simple. So
Okay.
it won't, because they'll be shorter, like 30 seconds.
Sure.
So it'll just be saying, here, we're here for you. We might pick specific segments on, to your point, IDD or whatever segment, but.
Okay. All right, thank you. All in favor signify by saying aye. Aye. All opposed? Motion carries. Item 5D, thank you. Request to approve Health Management Associates Agreement, approved by legal. Is there a motion? Motion by Phil,
Support.
support by Selena. Tracy, it's all yours.
If you recall, we had a needs assessment that was provided to us, the completed version in January of 2023. We are required to complete a needs assessment. This particular assessment will build off the one they did the previous time. What's nice is it'll give us a direct comparison of what they did and then how is it this. We're also asked them to do, if you compared what they proposed the last time versus this time, you'll see an expansion in the way that the CCBHC requires us also to do needs assessment, but it has very specific specifications. So you'll see that they'll mention that they meet those CCBHC specifications. So not that our motive is to check a box, but it does allow us to meet that particular requirement. So again, the request is for us to use this information as part of our strategic organization plan to better understand the needs of the community that we serve.
Any questions for Tracy? All right, all in favor signify by saying aye.
Aye.
Aye. All opposed? Motion carries. Item 5D, request to approve contracting with Trizetto Provider Solutions. I know I butchered that. Is there a motion?
So moved.
Support.
Motion by Dana, support by Selena. All right.
Hi, good evening. What we're talking about this evening is clearinghouse. Now, we currently use Optum, which is one of the clearinghouses, in order to process our claims. And for those not familiar with that, that is when we send our electronic claims, it goes through a clearinghouse that then helps review and edit those claims to be sure that they're accurate and then sends them on to the respective payer so that we can get paid. So again, we currently use Optum. We're going to be changing over to Trizetto, and a couple reasons for that is Trizetto is working real closely with PCE, which is our electronic health record. So there'll be some integration there, which then brings on some efficiency. One of those examples would be electronic insurance verification. So as we see this growth in our CCBHC, there's obviously more volumes coming through various insurances, and this would help our staff be more efficient, more accurate, more timely in being able to do that insurance verification. In addition to that, we have very hard to read patient statements. And as we all know, healthcare is already complicated, and when you get a statement that is very difficult to read, A, it's frustrating, but B, we may not get paid on that. So this is a very user-friendly, very patient-friendly type statement that will be produced and, again, improve that readability. So this is a function that, again, is currently being done by Optum. It would not be a function that would displace or in any way be something we would do in-house. This is a third-party system that all health systems use to do electronic claims. Hopefully that was enough information, but I'll take any questions.
Thank you, Tony. Any questions? All right, all in favor signify by saying aye.
Aye.
Aye. All opposed? Motion carries. And Tony, I think you have one more.
Yeah, I'll stay up.
All right. Motion, is there a motion to request to approve contracting with Payground Incorporated?
Support, Lori.
Motion by Donna, support by Lori. Tony?
Ryan, I appreciate it. I've called this playground so many times.
I
but
paused.
you
You
got it
guys,
right.
come on.
Yeah, I don't know how they came up with that name, but so Payground, this is actually going to be a new service, and in partnership with Trizetto, this is the credit card processing company that they use. Currently, we do not have this functionality. What does that mean? That means if any of our consumers have a patient balance, they present to the clinic and they'd like to pay their bill. If they didn't bring their checkbook, they can't pay us. And if they offer us cash, we really don't want to take that because it brings in a lot of internal control issues. What this will do now is allow our consumers to pay by credit or debit card. In addition to that, when they get that patient-friendly statement, there will be an option on the statement where they can then pay by credit or debit card, instead of having to go get a money order or a check and mail it to us. And we all know that in this day and age, most people do all of their processing through credit card and debit. So it's going to make it much more efficient for the staff, much more a better process for our consumers. And then from our collection, I'm expecting we're going to see an improvement in the collection of those balances due. In order to do that, we need a payment processing company. And again, Payground is the one that works with Trizetto, so it was a natural selection to work with them. In terms of fees, they all charge basically industry standard fees. It's a 3% per transaction. That's pretty much the going rate.
Any questions? I have a question. Who pays the 3% fee? Is it the consumer or do we pay?
We as the merchant would pay that fee.
And is that paid for credit cards and debit cards or credit cards only?
It's credit card, or if a debit card is pushed as a credit card, then you incur the fee. If they use their PIN, then there's no fee, which is
Okay.
very similar to what we would do in any of our day-to-day transactions.
Okay. So it's not like when you go to the gas station where you pay more if you're paid for credit. The consumer's not
Yeah,
going
we
to,
would
it's not going to cost our
We would
individuals
not
anything.
pass that on to
Okay.
the consumers.
Good. Any other questions? All right. All in favor signify by saying aye.
Aye.
Thank you, Tony. Motion passes. There's nothing to receive and file. There are no resolutions. Tracy, do you have an interim CEO update?
Yes, so in front of you, just drawing your attention to today, Macomb Daily, I will put it in the CEO report that you'll receive in the next couple weeks. But there is an article on our Mental Health Matters Awards. They interviewed some past winners, and they have a few quotes from us, so we're excited. You also will see our additional push by us related to that subject. You will, as you know, have already been receiving a lot of emails from us on that subject. But we actually are working with CBS News. So in the month of March, we'll be recording some interviews, including past award recipients, to then air those. Again, to promote and encourage people to nominate. I think I looked earlier today, I think we have 28 nominations so far, which is it's not what we want. Last year, if it's helpful, we had about 120 or so. So our goal was to obviously beat last year and then some. You also have in front of you, or you know what, the strategic plan, I'll just make a comment. Earlier today, you should have received a draft of it. I know Mark, thank you, has already found some typos, so I apologize ahead of time. Know that we're all very busy. But anyway, we're excited to get your feedback. That document, once you guys have an opportunity, will also be shared with like the CAC and several other organizations to, for them to be able to provide their input. It's currently also being edited and shared with the leadership team. Helen does have a great update on the Engagement Center, so if I could pass it to her for a second.
Well, we're happy to announce that we think we finally have secured a location for the Engagement Center. If you remember, that's going to be a location where people who are under the influence of alcohol or drugs can come, have a safe place to be, usually for up to 24 hours. But they'll work with peer recovery coaches on starting a recovery plan, and they'll link them right then to services if they're willing to accept help and care. If not, they'll do harm reduction techniques and just a lot of encouragement work to try and get people to get on a healthier track. So we're very excited. The property, many of you you might even have saw it on your way in today. It's on Cass. It's that older blue historic building right on the corner of Cass and Gratiot. So on the northbound Gratiot, so it would be on the west side, southwest side. So we worked with the landlord. He's very workable. TJ came out and did all his magic for us, which we greatly appreciate. He sent over a draft contract, so we've got that over to legal now. So we hope to bring that to you at the end of the month. He's on track to we need to have a bathroom, an ADA bathroom put in with showers, new flooring, some paint, some of those things, and he's trying to get us in there April 1st.
Oh, nice.
Yeah, so we're very excited, finally.
All right. Thank you.
I have questions.
Go ahead, Mark.
I know at one point we were talking about it could only be open 23 hours a day.
No, that's not true. It's,
that was-
it's 24 hours, 7 day a week. So we want to keep it that way because we want law enforcement to know that this is a place that they can drop off. We want hospitals to know this is a place they can divert to as necessary. We have our Project Assert peer coaches from CARE that work in our 3 hospital emergency rooms. They can also refer over here instead, for people who don't need the medical treatment, but they need a safe place to be. So yeah, it'll be 24 hours. The goal is, because they don't live there, they're not staying. So typically people are in and out within either a few hours or up to a day. It does allow if somebody needs to stay, let's say, for example, they're going to go into a residential treatment program, but the bed's not open for 2 more days. If they need that safe place, they can stay. It's just not any place that they're housed.
I thought at one time I read something out if it was considered residential. And then there was some zoning.
No, we're not worrying about that piece of it because, they can come and go. They can still come and go if they need to while they're there. And they're not, it's not like a recovery home where we're having them stay or any of those things. So just kind of be, you come and most people are gone in less than 24 hours.
I know I'm excited.
Yeah,
I
Good.
think if I can share a quick tidbit. Before I came here, we had a gentleman go up that was scheduled to go into treatment tomorrow.
exactly.
So we did get a place somewhere.
The night. Yeah, it's
But it
definitely a
took
needed
couple
service.
Hours of work to find somewhere.
We've had really good feedback from the law enforcement when we presented this before as part of the Safe and Healthy Macomb plan, which involves the opioid settlement dollars as well. And so both EMS and law enforcement, they were very excited to hear that they may be another place for them. And they did like to hear that it will be 24 hours because our past endeavor of trying to do kind of an urgent care approach was that it wasn't 24 hours. And so they didn't always know, like, are you open, are you not? So this hopefully will make it real usable.
Yes.
Is there a capacity to the number
Yes.
temporarily?
Yes, so so we're gonna determine what the space will allow. We're thinking for sure 8. We're trying, it's a 2-story house, renovated house. We're trying just to use the first floor until we get more experience, even though the upstairs is very usable. But at this point, I'm not comfortable having intoxicated people use the stairs for obvious reasons. But maybe if we had that person who, needed an extra day or 2 to get into a placement and they're fine, we might convert over time. But for right now, we're probably going to be starting with that and seeing how that spacing is. Ideally, we would have liked up to 12 at a time. But again, people are going to come and go throughout. So it'll be a quick turnover.
What are we gonna do for food service? Because if they're up there 23 hours, we're gonna have some type of breakfast, lunch, dinner, snacks.
Yeah, so we have a consultant working with us. I believe I spoke to you about it before, Marcy Scalera. So she worked with a previous PIHP. She's retired, but she helped open up 4 different centers. And so she's been our consultant on this, and she's also working at the state level to help PHPs with this project. So they already have guidance on food and things like that. It's not like full-blown meals people get, but yes, we're feeding them. There'll be snacks, they'll be able to have beverages, take a shower, get some rest in if they need it, sit back, maybe watch a little television while they're, kind of feeling better. But the real goal is, that peer work. And then connecting them with whatever resources they might need while they're there.
Any other questions? Tracy, you have anything else?
Just wanted to add, like, one of the mechanisms, because there is some possible perception of over 23 hours. Are you sleeping there? Do you live there? So Helen is trying to find what makes the most sense. When you have in the hospital room, you have the recliner that can turn into a bed. So I think that's also one of our mechanisms. So it's not really treated as a place to live, even in the short term. It's really a temporary setting.
Yes.
Yes. And we're looking towards, Helen and her team are looking towards purchasing the furniture quickly, so that way by April 1st, it will be ready for.
Yes. And we do have 2 different grant funds we're using for the startup cost of this project. So one does end soon. And so the state's allowing us, we're working with them on, what can we get versus, do we have to have it delivered and stored, or can we wait till, the grant's over, but still in that closeout period time? So we're working with them on that so that we don't have to double move furniture and things like that. So that's pretty exciting on that piece as well. The other grant will go through the rest of the fiscal year. And we do have a provider already selected through our previous RFP, and that'll be Care of Southeastern Michigan. They're a wonderful peer program that we use for a lot of different peer services, so it was a natural fit, and they did a great job with their application. That wouldn't be a resource that we would have for that, no, because it's not housing.
Right.
Yeah.
So we have to have all that.
Yes,
Time.
yes, and there will be policies, and we have draft policies already from our consultant, and so we will just kind of repurpose them into CMH policies for ours as we need it, but again, CARE will also have their policies as well to follow that we'll approve.
And what if somebody
No, it's kind of that welcoming, no wrong door. From past experience from our consultant, when they do have people who keep recidivating back, they really just work on them on changing and adjusting that recovery plan. Sometimes it's just a homelessness issue for the person. They're not really ready for treatment yet, so they're going to work on them trying to get appropriate housing too. But for some folks, that's the coming back and the coming back and the coming back. That's what eventually gets them into services and into recovery. So yeah, we're not setting limits. Yeah, we don't have that yet. And again, we'll go with those who have been up in existence for a long time for guidance.
And we're currently working with Airfoil, and we have a draft that they had already created, like a advertisement, right? So you'll start seeing those, and then we're trying to work on, like, are we gonna do an open house? What does that look like? How are we gonna educate the community? So we're currently developing that plan to align with the timelines that she was mentioning.
Thank you, Helen. Anything else, Tracy?
I do have one more item, I promise to be quick. So, one of the efforts, hopefully you guys like this, if not, give me feedback, is at one of the meetings every month, we're gonna take a particular program and quickly educate you on it and give you statistics. So in front of you, I have 2 motives here. You have 2 documents. One's orange like this, one's blue like this. They're actually identical in the way that it's describing services. I'm sharing with you the old one, the orange one. The new one of our initiatives is we've been working with Airfoil, and I hope that you find the blue one is much more visually appealing and simple when you actually read the words. It's a little bit more sophisticated, so I'm giving you that with the motive so you can compare what we had versus the direction we're going in our look will start looking more like this, and it will be more plain, where if you just glance at it, you'll see the needed information that you have. This particular one is on the crisis line. You guys already have a good idea of what the crisis line is. Just a friendly reminder, we have a local line. We do share that direct number, so that way a school or somebody wants to get your direct resources, they can get right to us. But we also, again, are one of the providers of the 988. So the way that works is if somebody has a 586 area code phone number, we are considered one of the solutions. but the provider or the main state level, they do monitor the levels. As an example, we tell them how many staff members we have available to answer the phone. Based on that, they send us so many calls. Does that make sense? So we now aren't necessarily answering every single call. If there's a high call volume, it's a way to ensure that every single call gets answered. So we are the state and part of the national solution for 988. In front of you, you have two charts. You have a little pretty bar chart, then you have a chart. I'm gonna explain this real quickly. First, I know I need glasses. I apologize if you can't read it, but if you put on readers, you might be able to. You'll see that this is the number of calls received specifically only to the crisis line for 2021, 2022, and it's 2024. I think they've mislabeled the years, just to be clear. I think it's supposed to be 22, 23, 24. You'll see that the most recent ones, ironically, we actually had the most calls in 2022 at the pandemic. So we did see an increase, and now it's actually decreased. But what was occurring is everybody's closed. They don't know where to call, so this is where they're calling. So it's now more leveled off. And the green is going to be this year as in October through January kind of numbers. The next page, if you don't know this, we have specific metrics that we're required to meet. Well, when I say required, they ask us to meet those. So we have an answer rate at no less than 95%. In other words, all the calls that come to us, 95% of them have to be answered. You'll notice it's in green because we're meeting that expectation. We have what's called a call abandonment rate that needs to be less than 5%. You have to be careful with the call abandonment rate because that means someone called and they could have hung up before we had a chance to speak or answer or anything like that. But it could also be someone that rang 3 times and they got annoyed, and it could be in numbers. But either way, we have an expectation for that to be less than 5%. Average speed to answer needs to be less than 20 seconds. You'll see that we're exceeding that. And the average handling time is less than 8 minutes. That is our own indicator. We established that indicator because one, it's about making sure everybody's being helped. But I'm sure, as you know, sometimes in crisis lines, somebody will call and the staff member needs to be able to get them the right help for them to be heard and then moved on to the next thing. So it's helping us make sure the staff understand how can we successfully do that. If someone has long call times, it's not a horrible thing, but we need to understand why they're outside of the norm based on this, because we've been doing this for many years and have a good understanding of what is needed. Then you'll see the total calls, and then you'll see outbound calls. If you don't know this, if someone calls and is maybe not suicidal or homicidal or to the point at which we think 911 or additional outside services are needed, we do offer other levels of care. They would be, hey, what if we check on you in 3 hours, right? And remember, it's anonymous, so someone doesn't have to. But if they want, then we will say, great, can I take down your information and I'm going to call you. And those are the outbound calls, examples of the staff members reaching back out and checking on individuals and encouraging them to seek help. So again, my motive is to give you updates, but also hopefully the goal is to give you stats to educate you on the various many things that we do in our organization.
Any questions or comments for Tracy? Any board comments? Okay, next item on, thank you, Tracy. Reminder, full board is February 24th, 28th. Program and budget is March 13th. And is there anyone from the public wishing to speak to this board?
I actually have a couple questions. How y'all doing? This is my first time at this, one of the Board of Commission meetings. I'm Ash Daniels. I'm a lead organizer with Michigan Liberation's Care Not Criminalization campaign. And I have maybe about 2 or 3 questions, if that's okay. So through many conversations with community members, we learned like there's a need for a non-police crisis response unit. And I was curious if there's been any conversation within this board about that. If not, who has the power to make something like that happen? So yeah, we'll stop with that question right there
And
first.
what are your other questions?
The other questions are, I heard you mentioning something, but like, what other mental health and substance use services are being funded by the ARPA funds and also the opioid litigation funds?
And what was your final question?
That was really it.
Those two, so what non-police crisis forms do we have, and what other services are offered by our department? Is that
Well, no, more specifically, like what's being funded by the
By
the
ARPA
ARPA funds and the opioid litigation funds.
okay?
Yeah,
Well,
those are the questions.
thank you. So,
problem.
and if you want to come up after the meeting and give your contact information, Tracy, someone can be in contact with you.
Absolutely,
All
thank
right,
you.
Thank you. Is there anyone else from the public wishing to speak to this board? All right, if there's no other questions, motion for adjournment is in order.
So moved. Support Lori.
All in favor signify by saying aye. Aye. We are adjourned.